Hello and welcome. This is the first in a series of 4 podcasts that will explore the issue of responsible psychotropic prescribing in adults with intellectual disability. The podcast discusses how to recognise symptoms of mental illness in adults with intellectual disability. Correct psychiatric diagnosis is the first step to ensuring that subsequent psychotropic prescription will be evidence-based and effective. Assessment of mental illness in people with intellectual disability may be challenging, but we hope this presentation will help. People with intellectual disability and comorbid mental illness often have more complex or atypical presentations compared to the general population. Depending on the level of communication ability, people with intellectual disability may have difficulties understanding their own experiences or expressing those to healthcare providers. Building rapport and making an accurate diagnosis can therefore be challenging. In order to meet these challenges, it's important to set aside extra time for appointments. It's not unusual for diagnosis of psychiatric symptoms in this population to require repeat assessments over a number of consultations. There are several resources on the 3DN website that can provide further information on how to adjust your practice to meet the needs of people with an intellectual disability. These include the Guide and the Intellectual Disability Mental Health Core Competency Framework and the associated Toolkit. Key assessment steps involved in making a diagnosis include obtaining background information, identifying presenting problems, performing relevant physical examinations, and formulating and testing potential psychiatric diagnosis. These processes are similar to assessment in the general population. However, within each step there are specific considerations for people with an intellectual disability. We'll now cover each of these steps in more detail. Obtaining background information. Background information to collect includes a comprehensive biopsychosocial history and a mental state examination. Previous medical and psychiatric assessments should be reviewed, and the cause of the intellectual disability should be ascertained where possible. This is important as some genetic causes of intellectual disability are associated with specific physical and behavioural phenotypes that may give rise to particular physical or mental health problems. Any family history of intellectual disability, autism spectrum disorder, mental illness or significant medical illness should be recorded, along with the information about the person's temperament, functioning level, educational achievements and developmental history. The person's level of intellectual disability and their communication abilities should also be determined, as these may affect presentation of symptoms. Identifying presenting problems. Explore the presenting problem considering the usual functioning and any recent deviations in function and enjoyment levels, changes in sleep, appetite, sexual behaviours, attention, mood, irritability level, or any specific or general anxieties, set routines or rituals, any preoccupation with death, dying or harming self or others, any auditory hallucinations, and any new or unusual beliefs or behaviours. A frequent bias that occurs during the assessment of a person with intellectual disability is diagnostic overshadowing. This refers to the tendency to misattribute psychiatric symptoms to behaviours associated with the intellectual disability itself. Diagnostic overshadowing contributes to under-recognition of mental health problems in people with intellectual disability and may lead to mental health problems being left untreated. Given the difficulties many people with an intellectual disability experience with identification and communication of emotional experiences, talking to other important people in the person's life may be helpful in piecing together a picture of the person's presenting concerns. Of course, you should always obtain consent from the person with intellectual disability or their substitute decision maker before doing this. To learn more about decision making, privacy and consent, visit Module 10 of the IDMH e-learning resource, which can be found at idhealtheducation.edu.au. Sources of information that may be helpful include family and friends, formal carers, staff of residential housing and employment organisations, school records and staff, past medical records including developmental and educational assessments, psychological reports and past behavioural support plans, and summaries of any previous medication trials, and lists of current medications. Compared to the general population, people with an intellectual disability are less likely to self-refer for mental health issues. It is often a carer who refers the person for assessment. Carers, however, are more likely to make a report if the person displays challenging behaviour rather than if the person is depressed or non-disruptive. In some cases, this referral bias may lead to an overdiagnosis of certain symptoms such as challenging behaviour and an underdetection of other conditions such as depression or anxiety. Performing relevant physical examinations. People with an intellectual disability experience a high number of medical comorbidities and communication difficulties. It's important to exclude any physical health problems which might be triggering disruptive behaviours before making a psychiatric diagnosis. Disorders associated with pain such as constipation, gastrointestinal reflux, musculoskeletal disorders and dental issues are common in people with intellectual disability and may trigger behaviours such as aggression or irritability, which could be misattributed to symptoms of mental illness. Basic assessments to carry out before formulating a diagnosis therefore include blood tests to determine the full blood count, urea and electrolyte concentrations, liver biochemistry and thyroid function, urine microscopy, culture and sensitivity, and depending on the presenting symptoms, consider also a head, CT or MRI scan, and testing for vitamin V deficiency. An EEG might be necessary if epilepsy is suspected, and exclude possible constipation if suspected with an abdominal X-ray. Formulating the psychiatric diagnosis. Presentation of mental illness in people with an intellectual disability varies considerably depending on each individual's verbal capacity and their ability to identify and communicate their subjective emotional state. Mental disorders will generally present very similarly to the general population in people with mild intellectual disability and good verbal skills. In such cases, standard diagnostic tools such as DSM-5 or ICD-10 can be used to help formulate a diagnosis. People with limited verbal abilities and people with moderate or severe intellectual disability may express symptoms in more atypical ways. In these cases, adaptations of the ICD and DSM may be more appropriate to use when considering making a diagnosis. Diagnostic tools adapted especially for people with intellectual disability include the Diagnostic Manual Intellectual Disability or DMID and the diagnostic criteria for psychiatric disorders for use with adults with learning disabilities or mental retardation, known also as DCLD. Where an individual has limited verbal ability, the clinician must rely more or solely on behavioural equivalents of psychiatric symptoms when formulating a diagnosis. For example, a patient with more severe intellectual disability may not identify or report a depressed mood, but this could be inferred from behavioural equivalents, such as an uncharacteristically sad affect, increased frequency of tearfulness, lack of interest in previously favoured activities, and so on. Behavioural equivalence, therefore, can be directly observed during the assessment process or may be reported by another person, such as a friend, family member, or formal carer. In order to give you a better sense of these behavioural equivalents, Dr. Bruce Chenoweth will now discuss behavioural equivalence of psychiatric symptoms in adults with an intellectual disability.
Hello, my name is Dr. Bruce Chenoweth. I'm a consultant developmental psychiatrist, and I've been interested in intellectual disability, mental health now for over 25 years. But today I'd like to introduce a friend of mine, Donna. She's aged 34 and she has Down syndrome, a trisomy 21. She also has mild to moderate intellectual disability. She's the middle of 3 siblings. She lives at home with her parents and up until 2 years ago was a bright, vivacious young woman who enjoyed her work placement and had a very full social life. Now, some 2 years ago, she became preoccupied with a certain person at work and became extremely anxiously attached to that person. She also became anxiously attached to her parents, and her work suffered. She was unable to concentrate, she was unable to perform her tasks. But in addition, over the subsequent few months, she lost interest in most things. She was forgetful and irritable, oppositional and stubborn, quite different from the young woman she'd been. She had dropped a lot of the activities in daily living, the ordinary hygiene, the ordinary chores that she did around the house. They were all going by the board. Her appetite was reduced. She stopped reading. There was some social isolation, and as I said, her work performance had dropped right off. So there'd been 2 years of increasing loss of functional capacity across every domain, at home and at work. The parents blamed the workplace dynamics and their own insensitive handling of her attachment to this supervisor. Workplace changes had occurred with the loss of supervisors over the last 5 years. Desperate, the parents took her to a series of psychologists. The standard techniques of relaxation and distraction and diversion didn't work. Mindfulness training was resisted at all times. Most people will jump on the bandwagon and say, we know that Alzheimer's is extremely common in Down syndrome. At 34, this must be the early onset of Alzheimer's. And they will perhaps not pursue investigations further. So what about Donna? She's at apparent memory deficits, mostly for new learning, has lost some of the complex language and reading skills, becomes very easily disoriented, has loss of interest in grooming, and has psychomotor retardation. Pathological slowness is not uncommon in Down syndrome in the early stages of dementia. She had that. And early insomnia and early morning awakening. Is this early Alzheimer's disease? It would be very, very unusual at 34. The rapid progress of functional decline suggests otherwise. Also, late onset epilepsy is very common in Down syndrome in the early stages of Alzheimer's disease. She did not have that, and there's certainly no incontinence. So the differential diagnosis was, is there a medical problem such as hypothyroidism associated with Down syndrome? Is it depression? Very common in Down syndrome. Generalized anxiety or obsessive compulsive disorder, or perhaps a psychosis not otherwise specified. Depression in Down syndrome differs from the general population. Cognitive features predominate. Memory concentration may be somewhat less. Psychomotor retardation is common. Disturbed sleep, loss of appetite is more common. And the pathological slowness of Down syndrome. That pathological slowness is frequently seen in Down syndrome, early dementia, and Down syndrome depression. So what do we do? We did a very comprehensive medical review, including the mandatory CHAP tool. We did an EEG and an MRI. In general, the many mental states are not helpful in someone with a mild to moderate intellectual disability. There is the D-SQUID, which is the Dementia Scale Questionnaire for those with an intellectual disability. We use that most. Clinical assessment probably is the most valuable. Finally, beware of diagnostic overshadowing. Because she has an intellectual disability and has Down syndrome, so much of the behaviour may be written off or ascribed to the disability, and an underlying and very common psychiatric condition may be overlooked. Thank you very much.
While specialist intellectual disability psychiatry services are not freely available throughout Australia, some small specialist teams do exist in major metropolitan areas. In complex cases, where you feel a second opinion would be beneficial, you can make a referral to such a service. The Intellectual Disability Core Competency Framework, practical toolkit for mental health professionals, which will be available on the 3DN website, contains a list of specialist intellectual disability services. Having established a psychiatric diagnosis in your patient with intellectual disability, the next step is to decide on treatment, including what, if any, psychotropic medication might be appropriate to prescribe. This topic will be covered in our next podcast. Thank you for listening.